Good evening, doctors. I'm thrilled to welcome you all for today's informative webinar on reproductive endocrinology. I am Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the day, Dr. Arshia Said. Dr. Arshia, an accomplished obstetrician and gynecologist with an MS in obstetrics and gynecology and extensive experience in tertiary care teaching hospitals. She is currently serving as an assistant professor and has significant clinical expertise in high-risk obstetrics, obstetric emergencies, operative obstetrics, gynecological surgeries, and basic laparoscopic procedures. Dr. Arshia is actively involved in undergraduate and postgraduate teaching, mentoring residents, and conducting academic activities, including seminars, journal clubs, and skill-based training sessions. She has contributed to several research publications in reputed national journals with special focus on maternal health and critical care obstetrics. Her professional interests include postpartum hemorrhage management, obstetric ICU care, operative obstetrics, and simulation-based medical education. We are delighted to have you with us, Doctor. Doctor, over to you.
Hello, everyone. Am I audible?
Doctor, you are loud and clear.
Okay. Thank you for the introduction. Just give me a moment.
You're so lazy.
Are the slides visible?
Yes, Doctor, it is visible.
Okay. Hello, everyone. Thank you for introducing me to the audience. So let's start today's session. So today, the topic that we're going to be discussing is reproductive endocrinology. So introducing you to today's topic, it's basically the understanding of a woman's journey. Okay, most of you must have heard these jokes on, how a woman is treated. Like if she goes through a phase, she's always called as hormonal, or she's probably PMSing. Okay, so a lot of things gets attributed, or her behavior gets attributed to hormones. Okay, how many of you agree on that? Is that a right way of describing? You all have your own set of answers, maybe. So have that in your mind ready. Let's go through this journey, and at the end of the session, maybe we can get answers then. Okay. So when we talk about reproductive endocrinology, things that we need to get in order first is understanding what is HPO axis, that is hypothalamo-pituitary ovarian axis. Okay. Once that is understood, next we'll move on to the menstrual cycle. Okay, very important to understand how the menstrual cycle occurs. Okay, what are the various phases in the menstrual cycle? Okay, the hormonal part of the ovarian cycle of it, the uterine axis of it. Okay, understanding of all of that, and then we go through the phases that a woman has to go through. Okay, first she hits puberty. Okay, that's when you call that the girl has entered womanhood. Okay, and then the transition goes to her being a mother. That's when she goes through the phase of pregnancy. And after that, when she has to nurse her newborn, she has to go through the phase of lactation. And finally, when all her duties gets over, she finally enters into the phase of menopause, where you can see that she's finally attained her old age. Okay, so and in brief, we'll go about in how this endocrine gets disrupted during various pathological factors. So shall we start today's session? Okay, so as I have told you, first thing we'll be discussing is the hypothalamo-pituitary ovarian axis. Okay, so in a female, what happens is you have one the center, the boss. Okay, the brain is the boss. Okay, and the boss sends signals to the ones who are their subordinates. Okay, so the main boss, that is the hypothalamus, okay, it will send signals to the next subordinate, okay, that is the pituitary. And then the pituitary will become the immediate senior for the ovary, okay. So the target organ is the ovary. That is the gonad in the female is the ovary, okay. So, so now for this HPO axis to work, the first signal is sent by the hypothalamus, okay. The hypothalamus will send the hormone, that is gonadotropin releasing hormone, okay. And that signal is received by the pituitary. In pituitary, you have the anterior pituitary and the posterior pituitary. So the anterior pituitary further sends the next set of hormones that it releases is the luteinizing hormone and the follicular stimulating hormone. Okay, and these two hormones will act on the ovary, and then the ovary releases two more hormones, that is the estrogen and the progesterone. So this is in a very simple way that I've explained what is the hypothalamo-pituitary-ovarian axis. Okay, once you've got this right, we'll go much more into detail about it. Okay, so the main control system is by the hypothalamus. Okay, now that hypothalamus will send signals to the pituitary via the gonadotropin releasing hormone. Pituitary via FSH and LH will stimulate the ovary to secrete estrogen and progesterone. Now, what happens is this entire pathway has to get regulated. Okay, it cannot go disarray. Okay, it means that when something is coming in excess, it needs to send a full stop back. Okay, now it's getting too much. Stop. So that is a negative feedback. Okay, and then there is something called the positive feedback. Positive feedback is the signals are being sent in such a way that no, it's not adequate enough. Send more. That is the positive feedback mechanism. Okay, so what happens is now for this positive or the negative feedback to take place, there is something called the long loop, the short loop, or the ultra short loop. In the sense, now if the ovary has a lot of estrogen and progesterone, okay, it can directly tell its immediate senior, that means the pituitary, okay, to stop, or it can and the pituitary in turn will tell its senior, that is hypothalamus, to stop. Okay, so this is the long loop. Next, you have the short loop. In short loop, what happens is the pituitary will get the signals that no, whatever hormones that I am stimulating to the ovary is a lot. So I need to tell the hypothalamus to stop. Okay, so that is the short loop, okay, in which the pituitary is telling no to hypothalamus, or no or yes. Okay, it can be either positive feedback or a negative feedback. And then you have the hypothalamus itself regulating its own self. Okay, it means the hypothalamus has the understanding that no, whatever I am sending, the GnRH from my side is a lot or is too less. So I need to ensure that I need to secrete either more or less. Okay, so these are the loops, in the sense how it's going to regulate this entire HPO axis. How it should get regulated is it's defined is it takes place through these loops. Okay, so either by long loop, short loop, or the ultra short loop. Either by any of these loop, it can send positive feedback where it wants more, negative feedback where it wants less. Okay, fine. So see, this topic on reproductive endocrinology might seem a little dry because these are more of concept-based learning. But the fun part about concept-based learning is that once your concepts are right, once you have them at your fingertips, it gets much more easier to understand pathology. Okay, so kindly keep up and try to understand this basic physiology, because only when physiology is understood well, will the pathology becomes easier. Okay, so what is this hypothalamus? So this hypothalamus, it is located at the base of the brain, behind the optic chiasma. Okay, it forms the base of the hypothalamus, it forms the tuber cinereum, okay, which merges to form the pituitary stalk. So the hypothalamus is attached, in the sense the pituitary is attached to the hypothalamus. Okay, looks more like the hanging of a grape. Okay, and this origin, so this origin of it is called the median eminence. Now, it's not just GnRH that the hypothalamus secretes. Okay, the boss secretes so many other hormones. Okay, the other hormones being prolactin inhibiting factor, growth hormone, releasing hormone. So basically, all the releasing hormones it secretes. Okay, so the main get ready, steady, go is set by the hypothalamus. Okay, so growth hormone releasing hormone, thyrotropin releasing hormone, corticotropin releasing hormone, insulin like growth factor, melanocyte stimulating factor. So all the first yes is given by the hypothalamus. Only once it says yes, well, it's the main hormone that it secretes. Okay, the stimulatory hormones that it secretes will stimulate the end organs. So of our interest is gonadotropin releasing hormone. So now, once the stimulus from gonadotropin from the hypothalamus is sent, okay, that is the gonadotropin releasing hormone, it's sent to the pituitary. Now, its connection to the pituitary can be either through a portal vessel system. That means the anterior pituitary part is connected to the hypothalamus. That means the signals coming from hypothalamus to the anterior pituitary is via the portal vessel system. Okay, it comes through the bloodstream. But whereas the posterior pituitary, here the connection is by a neurohypophysis. That means it has a neuronal connection coming from the hypothalamus to the posterior pituitary. But this is the difference between the anterior pituitary and the posterior pituitary. As this image is the explanation of this image, where in the anterior pituitary is via the capillary system, okay, the portal system. And so that means the hormones from the hypothalamus comes via the bloodstream into the anterior pituitary. But the stimulus, the hormones, the hormonal stimulation from the from the hypothalamus to the posterior pituitary comes via the paraventricular nuclei. So basically, it has these neuronal channels, okay, the supraoptic and the paraventricular nuclei connection to the posterior pituitary. Okay, so some things that we need to know about gonadotropin releasing hormone is that it's a decapeptide. Okay, the thing about gonadotropin releasing hormone, it has a very short half-life, okay, just 2 to 4 minutes. Okay, it's and that's when, and after that, it needs to send some more signals. So the very unique factor about gonadotropin releasing hormone is it does not it doesn't go continuously. It's not like, okay, the brain is sending one wave of gonadotropin and it keeps releasing. That does not happen. It releases in a pulsatile fashion. Okay, some of it is released and then there's a pause. The next set is released and then there is a pause. So this is a pulsatile fashion of release of gonadotropin GnRH. Okay. And since it has a very short half-life, you cannot really, there's no blood test to really detect the level of gonadotropin. Okay, you can have preparations of gonadotropin, the lab preparations of gonadotropin, but you cannot really assess, you cannot really draw your blood to know the level of your gonadotropin. Okay, so it is via the LH levels that you can know the level of gonadotropin. This concept we will have further clarifications when we talk about the various pathologies. Just keep in mind about this, that you cannot really measure GnRH. It's only through the level of LH assessment that you can know the status of the higher or the lower level of gonadotropin in your body. So it so happens that this hormone, gonadotropin releasing hormone, it can get controlled by various factors. Okay, so the hormones like epinephrine and estrogen, they stimulate. Okay, they are somebody who wants more of gonadotropin getting released, but FSH and LH, on the other hand, along with dopamine, serotonin, opioids, they say no to a lot of gonadotropins being released. They say no. Okay, so there are stimulatory factors and there are inhibitory factors. Stimulatory is estrogen and epinephrine. Inhibitory is FSH, LH, dopamine, serotonin, and opioids. So that's what I was explaining is you have synthetic preparations of GnRH, okay, but you cannot really measure the level of GnRH. Okay. Then after hypothalamus, the next the signal that is sent is to the pituitary gland. The pituitary gland, it lies in the sella turcica. Okay, again, as discussed, you have the anterior pituitary and the posterior pituitary. Anterior pituitary, the adenohypophysis is by the portal connection. The neurohypophysis, it is via the neuronal connection. Okay, the anterior pituitary, it originates at the roof of the embryonic pharynx called the Rathke's pouch and controls and contains the chromophil and the chromophore cells. The posterior pituitary, the posterior lobe, it develops from the floor of the brain. So this pituitary gland, it has these cells which secretes the gonadotropin. Okay, so the gonadotropins are FSH, LH. The other hormones being secreted by the anterior pituitary are TSH and corticosteroid hormones. So of importance in our discussion today is the follicular stimulating hormone, that is FSH, and LH, that is a luteinizing hormone. So the anterior pituitary, it sends the signal of FSH. Okay. Now FSH, it controls the ripening of the primordial follicles. I'll just go through this and again I'll be reinstating it when I'm going to explain you the menstrual cycle. Okay. So this FSH, the follicular stimulating hormones, as the word describes, it is the hormone which stimulates the follicles that is present in the ovary. Okay. And when this FSH along with the addition of LH, what happens is it activates the secretion of estrogen. Okay. Now, what happens is the level of FSH, okay, will be at the lowest at the start of the cycle. Okay, it starts building up as the menstrual cycle starts. Okay, it reaches a peak at the 7th day of the cycle and it declines to disappear around the 18th day. Okay, again, I'll be explaining about this in the menstrual cycle, but just in a way to revise, I've just put up these points, okay, so that you have an understanding of what is happening in FSH, and then you understand it better when the menstrual cycle is explained. Okay, and another peak of FSH occurs when that occurs after ovulation. Okay, the half-life of FSH is 4 hours. Okay, just compare how it differentiates. It's different from the GnRH. Okay, and this FSH, okay, the secretion of it is regulated by estrogen levels. Okay, so more estrogen, it says no to FSH, and FSH will say no to GnRH. So FSH inhibits GnRH, estrogen inhibits FSH. Okay, and this FSH is also responsible for development of LH receptors in granulosa cells. Just get these concepts in your mind and we'll again discuss in menstrual cycle. Then you have another hormone secreted by the pituitary, that is a luteinizing hormone or the LH. Okay, the LH, the LH pulse occurs during sleep initially and later extends throughout the day. The LH surge is initiated by estrogen, okay, and it lasts for 48 hours. It is preceded by a small amount of progesterone 2 hours earlier. LH level doubles in 2 hours and the peak plateaus for 14 hours before declining. The progesterone secretion begins 34 hours after the LH peak. So you have the LH surge occurring, and after that, the progesterone levels increase. Okay. The LH, it's in conjunction with FSH, it activates secretion of estrogen. Okay. So for estrogen secretion to occur, you need FSH and LH. Okay. But mainly it has to occur because of FSH. Okay, this brings about the maturation of the egg, okay, and causes ovulation. LH stimulates the completion of the reduction division of the oocyte. Okay, following ovulation, it produces luteinization of the granulosa cells and the theca cells and initiates the progesterone secretion. The LH surge, it precedes ovulation by 24 to 36 hours. Okay, that is, and minimum of 75 nanogram per ml is required for ovulation. LH stimulates the secretion of testosterone, androstenedione in the ovarian stroma, which diffuse into the follicular fluid and are aromatized into estradiol. Now we have something called LH dipstick test. It is a test to detect the occurrence of ovulation. Okay, this might have seemed very dry because it's just, introducing you to what luteinizing hormone is. Okay, we'll understand better in menstrual cycle. Then you have, okay, now we've finished hypothalamus secreting GnRH, the pituitary secreting FSH and LH. Next, you have the target organ, that is the the ovaries, which secretes the estrogen and the progesterone. Now, the main source of estrogen are the theca cells and the granulosa cells of the Graafian follicle and corpus luteum. Adrenal cortex is the secondary source of supply. Estrogen is secreted as estradiol, that is the active form of estrogen. Okay, it is bound to albumin and sex hormone binding globulin in order to get transported in the inside the body via the bloodstream. Okay, it acts by binding to the cytoplasmic receptors in the cell. It is inactivated by liver and excreted as conjugates of estrone, estradiol, and estriol. Okay. One last concept before going to the main menstrual cycle. You have the two-cell, two-gonadotropin theory. Okay. So in the Graafian follicle, okay, of the ovary, you have something called the outer cell, which is called the theca cell. The inner cell is called as the granulosa cell. Okay, the theca cell, it gets stimulated by LH. Okay, so now we're talking about two cells. The two cells being theca cell, the outer layer theca cell, the inner layer granulosa cell. The outer theca layer, the theca cell, it gets stimulated by, okay, the two gonadotropin. One of the gonadotropin is LH. Okay, now under the influence of LH, cholesterol coming from the bloodstream, it gets converted into androgens. Androgens being androstenedione and testosterone. Okay, but the thing about theca cells, it is that they lack aromatase. Now, this aromatase is present in the granulosa cell. So now the androgen, which is somebody trying to say something? Somebody's microphone is on.
Yeah.
I think somebody's microphone is on. Could you please mute? Okay. Okay, so can somebody please ask? I think it's Suresh Sharma. His microphone is on.
Hmm?
Maybe the admin can ask, can mute him. Just 1 minute. I think it's fine now, right? I think that person, no, it's still not gone for mute. Okay, anyways, I will continue. I don't know how to stop this distraction. Okay. Okay, so I was
Dr.
explaining
Meena,
that
what is the distraction?
somebody was unmuted and there was a lot of disturbance from, I think it's
Okay.
Suresh
I'll
Sharma.
remove the.
No, I think now it's gone for mute, but it was creating a lot of disturbance.
Now I don't think you'll have it. I have made sure.
Okay.
Yeah, please continue. Sorry.
Okay, thank you. Fine, so let's continue. I was talking about the two-cell, two-gonadotropin theory. The two-cell being theca, the cell that we're talking about are the cells of the Graafian follicle. Okay. So this is the ovary. Okay. And in ovary, you have the various follicles. Okay. Each cycle, one follicle gets chosen. Okay. And becomes the Graafian follicle. In the sense, one follicle matures and forms and becomes a Graafian follicle. Okay, so now this Graafian follicle will have two layers. The outer layer is the theca cell layer, the inner layer, the pink one, okay, that is the granulosa cell layer. Okay, so now for the production of hormones, okay, that the estrogen hormone, okay, it is mainly you need both the cells, okay, and at the same time you need both the hormones, that is FSH and LH, because this theca cell, okay, the outer layer, it is regulated by luteinizing hormone, the LH hormone. Okay, now what this LH hormone does at the level of in the theca cell is it takes the cholesterol. Okay, estrogen, androgen, these are all cholesterol based hormones. Okay, so it takes in cholesterol, okay, and it converts this cholesterol to androgen, that is androstenedione. Now, we don't need androstenedione, isn't it? I mean, women needs estrogen. So now, in order for us to get this estrogen, what has to happen is this androgen needs to enter inside the granulosa cell, okay, the inner cell. Now, the advantage of granulosa cell over theca cell is that it has aromatase. But granulosa cell cannot take cholesterol inside it. Okay, that function is done by theca cell for it. So it's a shared benefit and a shared activity done by the theca cell and the granulosa cell. So once the androstenedione enters inside the granulosa cell, in the influence of aromatase enzyme, it converts the androstenedione into estrone. Okay, estrone is not the active form. Okay, the most active form is the estradiol. Okay, so now then that estrone gets converted in the presence of 17 beta hydroxysteroid dehydrogenase, okay, 1 and 2, and it gets converted into estradiol, which is the active form. Okay, and that estradiol is getting secreted into the bloodstream. Is this understood? It's a very important concept to understand two-cell, two-gonadotropin theory. Okay. I cannot see the chat box. Oh, yeah, I can see the chat box now. Could you please repeat? Okay, I will repeat, okay, because this concept needs to be understood. So what happens is you have two cells in the Graafian follicle, okay, that is the theca cell and the granulosa cell. So this theca cell, it has the advantage that it can imbibe the cholesterol inside it. Okay, it takes the cholesterol, it converts it into androstenedione, that is androgen. Okay, now we don't need androgen, we need estrogen. Okay, now who's going to get that for us? That function is done by granulosa cell, because granulosa cell will take this androstenedione which is formed, okay, and because it has this enzyme aromatase, it can convert this androstenedione into estrogen, okay, and that estrogen is utilized, I mean, for the functioning of a female. Okay, so this is two-cell, two-gonadotropin theory. And one thing I forgot to mention is this granulosa cell is under the influence of FSH. Okay, the theca cell is under the influence of LH. The granulosa cell is under the influence of FSH. So the two cells being theca cell and the granulosa cell, two gonadotropins being LH and FSH. So all these together combine and they give us the female hormone, that is estrogen. Okay. Now let's move on to the menstrual cycle. Okay, so before we go to the actual menstrual cycle, let me brief you out on the things that we need to know. In menstrual cycle, you have it is also you have the first phase of it, that is a proliferative phase, also called as the follicular phase. Okay, this part is mediated by estrogen. Okay, the duration of this can be of variable days. Okay, main thing that takes place in the follicular phase is the formation of follicles. Okay, the word itself becomes explanatory. The follicles are being formed. The recruitment of follicles takes place. Nearly 15 to 20 follicles will get recruited, okay, out of which one of them is selected and it grows to form the Graafian follicle or the mature follicle. Okay, now this phase of the cycle is under the influence of FSH, because this FSH will stimulate the production of the recruitment of all the follicles. Okay. And this FSH will stimulate the granulosa cell to release estrogen, isn't it? That's what we discussed. Okay. And the granulosa cell, what it does in turn, it converts the androgen into estrogen, and estrogen is the hormone which acts on various other organs at the end for the female reproduction to take place. Okay. It starts with, the menstrual cycle starts with the follicular phase or the proliferative phase, the first half of the cycle. Mid-cycle, it comes to the time where ovulation takes place. Okay. And then the last, second half. Okay. Mid-cycle, ovulation takes place. The second half is when the secretory phase starts. Okay. This phase is also called as the luteal phase. This phase is where the progesterone is being secreted. Okay. Fine. I think I'll go to this diagram first. Okay. Okay. I hope I have all your concentration now, because we are going to the main another very important concept to be understood. Okay. If you understand menstrual cycle, okay, then it will be easier for you to understand abnormal uterine bleeding, how to give contraception. Okay. How do you prescribe various OCPs? Okay. The action of various OCPs. Okay. And PCOS, understanding of PCOS, which is like a very important topic nowadays. Okay. So understanding of all of this is very important once you know menstrual cycle. Okay. So in menstrual, when you talk about menstrual cycle, you have two half. Okay. The first half is the follicular phase. Second half is the luteal phase. Now this, when you talk about both the phases, there are changes taking place in three areas. Okay. One is the hormones that are being secreted. Next is the changes taking place in the ovary, that is the ovarian cycle. And then is the changes taking place in the uterus. Okay. So these are the three areas that you need to talk about. See, like how this graph explains, you have the hormone level, changes in the hormone level, changes in the ovarian level, and changes in the uterus, that is endometrium. Okay. Changes at the level of the endometrium. These are the various changes that takes place. Okay. So three factors which change, okay, in the menstrual cycle. So now what happens in the follicular phase, the first half of the cycle, when I'm going to talk about the hormone level, the hormone which is getting secreted. Before that, I need to explain one thing. When you talk about menstrual cycle, you have day 1 cycle, day 2, day 3, day 4. You always talk in terms of the day of cycle. Okay, the patient is in. So day 1 of cycle is when her periods start. The commencement of menstruation is the day 1 of cycle. Okay, when she gets her periods, that is day 1 cycle. Okay, so day 1, what happens is your FSH level will be at the most lower level. Okay, and then you see a gradual rise in the FSH level. Why? Because at this point, the follicular recruitment takes place. Okay. So now for the follicles to recruit, you need follicular stimulating hormone. Isn't that easy? Follicles to get stimulated, you need follicular stimulating hormone. So follicles will get stimulated in the first half of the cycle. Okay. So what happens is there'll be a gradual rise in the when in the beginning of her periods, it'll be 0. Okay. When the period starts, as the period starts, with that the FSH level will increase. Okay. And once that FSH level, it reaches its high level at the 8th day, it gradually starts declining, because it has already recruited recruited the follicles, and then the graphene, one of the follicle will start getting matured. So the graphene follicle will start getting formed. You can see here, 8th day, the FSH has reached its high level. Okay. And then that's when the graphene follicle has formed. Okay. And then it gradually declines, because now its function is over. It has recruited the graphene follicle. Its level gradually starts declining. But then you see another peak taking of FSH. Now this peak takes place because what happens is the level of estrogen will be very high, a very sustained high level of estrogen. What it does is it sends a positive feedback. This is a little misnomer kind, because what you are understanding at this point is, okay, fine, high level of estrogen will say no to FSH, isn't it? But at this point, what is happening is this is a very sustained high level of estrogen. So in order for this sustained high level to continue, FSH will also increase so that it can further maintain that high level of estrogen. Okay, that is why you have a second peak of FSH. Okay, so please don't get confused in this. Why are you seeing another peak? Because, madam said FSH is, for follicular recruitment. Why is there another peak? This is the explanation why there is second peak of FSH. Okay, this takes place around the time of ovulation. And then the level declines in the second half of the cycle. You don't need FSH at all. So there is no second half of the cycle. You won't see FSH at all. Okay. The other hormone is the luteinizing hormone. The luteinizing hormone is something which we need for ovulation to occur. Okay. Now, this luteinizing hormone is this purple one. Okay. When at the start of the cycle, day one of the cycle, low level, as you're reaching almost the 10th, 11th day of your cycle, okay, the level starts rising. And 36 hours prior to ovulation, you see a maximum peak in the level of LH. That is called as the LH surge. Okay, there's a huge rise in the level of LH. Once that occurs, after 36 hours, the ovulation takes place. See, all this concept is very, very, very important when you're going to read infertility. A lot of these things will be better understood when you learn about infertility. Infertility, why we are giving, the ovulation induction medicine from the day 2 of cycle. That is because day 2 you have the maximum recruitment of follicles. So that is why you're giving ovulation induction drugs in the beginning of the cycle. Okay, day 2 of cycle. Then another concept which you have an understanding, okay, why we are giving, the importance of LH. Okay, we give this beta HCG injections, okay, so that the ovulation takes place, and that's when we need an LH rise. Okay, and also this LH levels, as I explained previously, you can do a blood, like how you have a UPTICA kit test, right? You can do a similar kit test for LH to know this LH rise, and indirectly giving you an idea about ovulation occurring or not. Okay, these are a few practical points that I wanted to bring across. Okay, then what happened? The next hormone that we need to understand in follicular phase is estrogen. Okay, now as we know, once the Graafian follicle has formed, okay, the two-cell two-gonadotropin theory, okay, just try to recollect that. So what it does is it will start increasing the estrogen levels. So estrogen levels will peak, okay, start peaking from day 6 onwards. Okay, it reaches its maximum around the 13th or the 14th day of the cycle, and then onwards, once so you can see the peak coincides with the formation of the Graafian follicle. Okay, so this is the proper Graafian follicle here. So once that Graafian follicle has ovulated, once ovulation has taken place, once the Graafian follicle ruptures, okay, this estrogen level will gradually start reducing. Okay, and then in second half of the cycle, again, you will see a smaller peak in the level of estrogen, because what happens is the corpus luteum, it also secretes some amount of estrogen. Okay, so that is why you see a second peak, because what happens is a second half of the cycle is more like a preparation for pregnancy. Okay, so in pregnancy, it's not just the requirement of progesterone, you also need some amount of estrogen. That is why you see another peak in the level of estrogen. Okay. Next hormone is progesterone. Progesterone is purely, I cannot say purely. Yeah, it's more like, something pregnancy is always, progesterone is always linked with pregnancy. Okay, it's like something which is preparing itself for pregnancy. So that is progesterone. Okay, it's easier for you guys to remember it that way. So there is absolutely no role in the first half. Okay, there is no formation of progesterone at all. Why? Because progesterone formation occurs only after the formation of corpus luteum. Okay, so that is why progesterone is seen only in the second half of the cycle. Okay, so this is how the hormone levels are. Again, I'll talk about the ovarian cycle. Again, I'll be reinstating the same thing. In ovarian cycle, what happens is, first half of the cycle, the recruitment of the follicles will take place under the influence of FSH. Okay. Then once FSH levels have risen, and then follicles get recruited, one particular follicle, it will have a very high number of FSH receptors on it. Because of the high level of FSH receptors, what it does is it will mature the most, okay, and become the Graphene follicle. The rest of the follicles which were recruited, which they thought they may turn lucky, but they didn't. They undergo atresia, and there's no more use of them. Okay, the other ones, the other follicles which were recruited, okay, they just die off there. So only the one follicle which has high number of FSH receptors, it gets selected, becomes a Graphene follicle, and then it reaches its maximum size. Okay, again, the Graphene follicle will have two layers. Yeah. So this is the ovarian cycle. Okay, in that you have this is the ovum. Okay, in the ovary. So now in the ovary you have the primordial follicle. The primordial follicle, which grows to become the primary follicle. Okay, it grows further and forms the secondary. It forms the Graphene. Sorry, here it forms the Graphene follicle. The Graphene follicle, it has the mature follicle. It has two layers: the outer theca cell layer, the inner granulosa cell layer. Theca cell layer under the influence of LH. Okay, and the granulosa cell layer, it is under the influence of FSH. Okay, and the Graphene follicle is the one which secretes estrogen. Okay, that is about the Graphene follicle. Then once the Graphene follicle has reached its complete big size, 20 to 24 mm it reaches, and at that point it ruptures. Okay, and that's when you see the peak of LH hormone, that is the LH surge occurs. Okay, and after 36 hours after the LH surge, will the ovum get liberated. Okay, this is the liberated ovum. Now what happens? The rest of the Graphene follicle, once the egg has released, now this released egg will have, will go in search of the sperm. So once the egg is released from here, it will go inside the fallopian tube, and it will wait for the appearance of a sperm. But if there's no sperm, it will also disintegrate and it will shed off during the menstrual cycle. Okay. Now what happens to the rest of this cover of the Graphene follicle? The rest of this cover will undergo a change under the effect of luteinizing hormone. Okay, and it becomes the corpus luteum. So luteinizing hormone will lead to the formation of corpus luteum. The words are the interplay of words, if you can, keep up with it, you will know the action and the effect of it. Okay, so it forms the corpus luteum. Now, this corpus luteum is responsible for the secretion of progesterone. Okay, so that means it's trying to prepare the body for, egg has been released. So now the body is thinking, okay, it might get pregnant. So it's a preparation for that. Okay, so it releases the progesterone hormone. Okay, and then it will remain. The progesterone level will remain in the second half of the cycle, waiting for fertilization to occur. But if there's no fertilization, this corpus luteum also disintegrates to form corpus albicans, and then the entire cycle of the entire ovarian cycle stops. Okay, it starts from primordial follicle. It dies as a corpus albicans. All this while waiting for fertilization to take place and secreting progesterone. So that is the ovarian cycle of the menstrual cycle. Then last we'll talk about what happens at the level of the uterus. So now at the level of uterus, you have the endometrium. Okay. Yeah. Yeah, I'll explain on this. So what happens is, at the level of the endometrium, under the influence of estrogen, you have the proliferative phase taking place. Proliferation in the form of the blood vessels will start proliferating. Okay, the lining, the endometrial lining will start proliferating. Okay, it all starts building. Okay, the basement is being formed. Okay, once that basement gets formed, in the first half of the cycle, under the influence of progesterone in the second half of the cycle, this the blood vessel, it becomes more coiled or tortuous, okay, because it feels like, it wants to penetrate into the growing fetus embryo, okay, so it becomes more coiled and tortuous, and then there is more it contains more of glands, stroma, the stroma becomes more edematous, okay. This is all in preparation for implantation, fertilization, implantation. For the implantation takes place in the endometrium, isn't it? So this is all the preparation for implantation. So that is why the second half of the cycle is a secretory phase, because more of stroma, more of decidulization taking place here, okay. So that is the second half of the cycle. It becomes more receptive for implantation to take place. Few concepts that you need to understand here is the um, progesterone can act only on estrogen primed endometrium, okay. So estrogen priming is very important for progesterone to act. That is one thing. And this concept is also needed for understanding of PCOS. Okay, what happens in PCOS? These are all not just PCOS. In any case of anovulation, if there is no ovulation taking place, there is no corpus luteum being formed. If there is no corpus luteum being formed, then there is no progesterone, okay. So uh, this is what happens in anovulatory cycles, where there is no ovulation taking place, okay. So these are all the changes taking place at the level of endometrium. Okay, so is menstrual cycle clear? Before I move on to the next set of concepts, I need to know if menstrual cycle is clear. Can I have a go ahead from the students? There is no reply from anybody, so I think I'm going to go ahead. Nobody wants me to repeat anything, right? I'll give a minute's time. No reply can either mean nobody's understood or everybody's understood. So I would just assume that everybody's understood the concept, and I will move on to the next topic, that is puberty. Okay, so there's nobody in the chat. Oh, there is. Okay, wait, I'm just going through the chat now. Okay, all good. Everything is clear. Last progesterone part you want me to repeat? Okay. Progesterone, progesterone part is actually very simple. Okay. What happens? Progesterone gets secreted in the second half of the cycle. Okay. And that it gets secreted by corpus luteum. That is the remaining part of the Graafian follicle. Okay. After the egg is released, it is the corpus luteum. So that secretes progesterone. So that this progesterone is seen only in the second half of the cycle. Okay. The other hormones, if you can notice, they have a little bit of play here and there as well. Like, FSH in the beginning, it will be there. Mid-cycle also, you can see a little bit of it. Okay, estrogen in the first half of the cycle, it was there. Second half, again, you can see a little bit of it. Okay, LH in that matter is very strictly, talking about ovulation only. Okay, and then progesterone is also something that's very strictly focused in the second half of the cycle for priming the for getting the endometrial bed ready for implantation. So what happens is this first half of the cycle, it will remain variable. But the second half of the cycle is always fixed, in the sense from the day you've got your first day of cycle, minus 14 days is always your second half of the cycle. Second half of the cycle is always fixed duration of 14 days. Okay. Okay, please go on. Okay, now I've got to go ahead. So I'm going to go on to the next topic. That is, I don't know. Okay, fine. So now, since we have understood, the interplay of hormones, okay, taking place, and how it gets regulated, how it gives signals for it wanting more or it wanting less. Now that means the HPO axis. Okay, now that we have understood all of this, now we are going to talk about the phases that I was talking to you about. Okay, we are going to talk about puberty. We're going to talk about pregnancy. We're going to talk about lactation. Okay, and then menopause and contraception. Okay, so so with this we will get an understanding of how exactly it's the application of this HPO axis is the application of the menstrual cycle, and how the interplay of all the hormones, GnRH, FSH, LH, estrogen, progesterone, the interplay of all these hormones, practically what happens at each phase of life is how we're going to talk about with the beginning of puberty. Okay, puberty, what happens is the HPO axis gets activated. Okay, initially it's just the nocturnal secretion. Okay, and then after that the secretion takes place throughout the day. Okay. Then okay, so what are the stages of puberty? First you have thelarch. Thelarch is the development of breast. Okay, the development of breast is mainly done by estrogen. Okay, you need estrogen for development of breast. Pubarch is okay. Pubarch is the development of the pubic hair, the axillary hair. Okay, that is what is pubarch. Arch always refers to beginning of something. Okay, then you have the growth spurt occurring, and then the last step of puberty is menarche. Menarche is the first occurrence of menstrual cycle is menarche. Okay. Um, so in thelarch, what happens is there's the development of breast tissue. Okay. So mainly the development of breast tissue is under the influence of estrogen. So estrogen comes from ovaries. Okay. So please get all these concepts right, because it's very important what happens in Turner syndrome, gonads fail, what happens, to understand all of that. All these concepts is of utmost importance. Okay. So estrogen is the one which leads to the development of breasts. Okay, then you have adrenarche. So for the formation of axillary and the pubic hair. Okay, so basically we're talking about secondary sexual characters. Okay, for secondary sexual characters to occur, you need estrogen, and you need the production. You need the secretion of androgenic steroids, that is dihydroepiandrosterone and dihydroepiandrosterone sulfate. Okay, DHE and DHEAS. Okay, so this is getting secreted by the adrenal cortex. Okay, now under the influence of this, there's development of axillary and the pubic hair. So this is also one of the secondary sexual characters. Okay. So when you tell that somebody's hit puberty, you need to know that they have one thing is the breast has developed. Okay, there is presence of axillary hair, there's presence of pubic hair. Okay, and then there are changes taking place in the vagina, changes taking place in the labia majora, labia minora. Okay, all the female external genitalia. Okay, changes in that. Okay, taking place, that is also as a result of puberty. Okay, and then there is a growth spurt. Growth spurt is a sudden increase in the height. Okay. In females, what happens is the growth spurt occurs much more earlier compared to the male. Okay, this is under the influence of growth hormone and estrogen. And once this initially, what estrogen does is it will accelerate the height. Okay, once that acceleration has taken place, it leads to even the it even puts a full stop on that. That is by closing the epiphysis. The epiphyseal plate is what is responsible for the increase in the length of the bone, isn't it? But initially it'll accelerate the growth of the bone, and then after that what it does, it just puts a stop. Okay, so what we females go through is we'll have a sudden increase in height, and it stops at that. Okay, that occurs because of epiphyseal closure of estrogen. Okay, then you have the last step taking place is that of menarche. Menarche is the first onset of the menstrual cycle is menarche. Okay, what happens is initially this HPO axis, we discussed the axis, right? Okay, but it will not for this axis to actually become very regular and very strict. For it to get followed very strictly, it takes time. Okay, that means what I'm talking is about the maturation of the HPO axis. Okay, initially when she hits puberty, this HPO axis will not be mature enough. It may take 2 to 3 years, okay, for this HPO axis to become mature enough for it to work in that proper rhythmic manner. Okay, that is why the first half of the cycle can be anovulatory cycle. Just 1 minute. So that is why the first of the cycle can, you tend to hear complaints from patients, mothers, especially getting, a girl who's just hit puberty, they'll give complaints that, no, my child, she's not having her cycles every monthly, she'll bleed either 2 months, 3 months, in 3 months, once in, 4 months. So the cycles are not very regular. These are the usual set of complaints that you can see some girls who have just hit puberty. Okay, that is because the HPO axis is not mature enough. It takes some time. You just have to reassure them, the first cycles, because they're anovulatory, because the HPO axis is not, mature enough, that, you'll not see the proper cyclical periods. Okay, once it's mature, you will get to see the proper cyclical periods occurring, every month. Okay, so for this, for the puberty to start, okay, so the main control system is at the level of the hypothalamus. This hypothalamus, which was initially dormant, okay, because of the inhibitory effect of adrenal cortex, okay, because we studied that cortisone will inhibit the GnRH secretion, okay, so it will be under the inhibitory control. Okay, once you've hit puberty, okay, the sensitivity of this hypothalamus, it starts becoming sensitive around 8 to 12 years. Okay, that is when somebody will hit puberty, isn't it? That's the age group of having puberty, between 8 to 12 years. So that's because the hypothalamus becomes sensitive during this time. Okay, it gets fully established. That's what I was talking to you about. The HPO axis, for it to become completely mature, fully established, it occurs at the age of 13 to 14 years. So till then, you can reassure the patient that no, it's going to take time for the cycle to become regular. So just reassure them. Okay, and this hypothalamus will start secreting GnRH. Okay, and GnRH, as I explained, that it's a pulsatile secretion. Okay, in females, but in male, it gets secreted continuously. So once we've spoken about puberty, here is a patient, an 8-year-old girl. Okay, what is Tanner staging? Tanner staging is basically you're going to assess the development of secondary sexual characters. Okay, that assessment which you can do as a clinician is you're going to check for the development of breast, the appearance of axillary hair, the appearance of pubic hair. Okay, that, and then you give a stage. Okay, Tanner staging 1, 2, 3, 4, and 5. Tanner staging 5, 4, and 5 are that of a mature girl. Tanner staging 2 and 3, that means it's still not completely developed. It's still in the developing phase. Okay, so what we discussed is uh, puberty hits after 8. So this is an 8-year-old girl. Okay, so at 8 years itself, she's already had, telarc has set in. Okay, she has had her growth spurt, and now she's starting to see a menstrual bleed as well. Okay, in the form of occasional spotting. So what are we talking about? I just want to answer this question. Ovulation differs from time to time. Yes. So is it fixed? In this case also, last 14 days will be fixed. Yes, last 14 days is always fixed. It's just the first half of the cycle which can vary. The duration varies. When you tell that somebody is having a 35-day cycle, 40-day cycle, 21-day cycle, whatever the length of the cycle is, the ovulation always occurs from 14th day minus your day of periods. Okay. Yes, somebody's answered that this case scenario is that of a puberty which has set in early. Can somebody give me the exact diagnosis, the medical term? She's explained it. Yes, there is a puberty which has occurred early. Can somebody give me an exact diagnosis for it? And it's always good to have interactive students. Yes, thank you. So we're talking about precocious puberty. It's okay to have no idea. It's fine. But, that's why I'm here to give you an idea. Okay, so yes, we are definitely talking about precocious puberty. Okay, it's not, the spelling is different. Okay, it's not the one which you have mentioned. Precocious means the occurrence of puberty early. Okay, before 8 itself, she has had a thelarch, she's had growth spurts, she's had menarche. Okay, so this girl is somebody who is having a precocious puberty. Okay, that's the correct spelling. Precocious. That is the correct spelling of precocious puberty. Okay, so puberty occurring early. So why does this occur? So this can occur because of two reasons. One thing is the main boss, that is the hypothalamus. It has, matured early. Okay. It's starting to send signals faster than when it should have actually started. So what we spoke about is the sensitivity of hypothalamus. It starts between after 8 till 12. But in this child, what has happened is it's become sensitive much earlier. Why has that occurred? Okay. It could have occurred either because of a central cause, that is the problem at the level of the hypothalamus, or a peripheral cause, that means the problem at the level of the ovary. Either the ovary is, overactive and starting to secrete more of estrogen. Okay. In conditions where there can be an ovarian tumor, McCune-Albright syndrome. Okay. Or if there's congenital adrenal hyperplasia, okay, because of adrenal secreting more of androgen and that leading to conversion of more into estrogen. Okay, so what you need to understand is precocious puberty occurs because of increased estrogen levels. Estrogen levels can increase because of two factors. One is at the level of the central cause. If there's any hypothalamic tumors, okay, or infections or any trauma, okay, because of this, the hypothalamus suddenly become active before it's given time. That means before the age of 8, and it's secreting more of GnRH, more of FSH, more of LH, more of estrogen. Okay, so that is the central cause. Otherwise, you can even have a peripheral cause. Peripheral cause means the end organ. The end organ being your ovaries, okay, which will secrete more of estrogen, leading to precocious puberty. Okay, what about this child? Okay, 15-year-old girl, presents with no breast development, no menstruation, and she has a short stature. What about this child? What is the problem in her? Yes, so the other end of the spectrum, that is delayed puberty. We say that the puberty is delayed if by the age of 13 years she's had no secondary sexual characters, and by the age of 15 the menses has not started. So that means there is amenorrhea, or she has not attained menstruation. There's no menarche by 15 years of age. That is when you say that the child, the girl, is having a delayed puberty. Okay, so because of no puberty being hit, okay, so definitely there'll be no breast development and there will be no menstruation. Okay, and then as we spoke that GnRH is estrogen is also responsible for growth spurt. So this child is having a short stature. Now, why do you think this child is having external cause of precocious puberty? Yeah, definitely. There can be an external cause of precocious puberty if exogenously you've given them steroids. Okay, steroid consumptions. Okay, this can also lead to precocious puberty. Where exogenously you're giving steroids, because as I told you, estrogen androgen. These are all steroid hormones. Okay. So that can be an external cause for precocious puberty. Okay. Yeah. So why has this child not attained uh, uh, um, menarche, not attained puberty? That is because of delayed puberty. The delay can be, the delay can be because the hypothalamus is not secreting, that is hypogonadotropic hypogonadism, or they can be hypergonadotropic hypogonadism. So the fault will be at the level of the ovary. The ovaries are not secreting estrogen. This can occur because either the ovaries are failed. Okay, that is hypergonadotropic hypogonadism. That means the brain is trying to send signals. Okay, but the ovaries are not acting. Okay, conditions like Turner syndrome, where the stimulus is there from the brain, but the end organs, the ovaries are not able to produce estrogen. So that is hypergonadotropic hypogonadism. The hormones are being secreted from here at the higher up, but it's not acting on the end organ, that is the estrogen. That is hypergonadotropic hypogonadism. Then there is another condition where they can be hypogonadotropic hypogonadism, where the brain itself is not sending signals. Okay, and because of that, it's not acting on the end organs. Okay, so it can present in either one of the two ways. There are a few questions. Yeah, we will talk about the reasons and Turners and everything. If you all could answer these questions for me. Can I have answers to this question? I will address your doubts for sure. Okay, so this question is, a 7-year-old girl has breast development. Okay, so 7-year breast development, we're talking about precocious puberty, isn't it? But the LH level is low, and GnRH test shows no rise in LH. What is the diagnosis? So here we're going to be talking about how to differentiate if it's a central precocious puberty or a peripheral precocious puberty. Do you all agree with me that it cannot be delayed puberty? No, the answer cannot be delayed puberty. It has to be either, it's a 7-year-old girl who has breast development. So obviously it can be either, it is not normal puberty, it is definitely not delayed puberty. It is either one of these two. It could be either central puberty or central precocious puberty or peripheral precocious puberty. Now, how to differentiate these two? So what happens is, in central precocious puberty, the GnRH level will be high, because of which the LH level will be high. Okay, center is acting perfectly. No, it's secreting more rather. But in peripheral, what happens is there is no much secretion from higher up. So because of that, the LH level, which is at the level of pituitary, that will also be low. So finally, when you're checking for the LH level, you can always check the LH level in your body. Okay. There are blood tests to check FSH level. There are blood tests to check LH levels. But when you're doing the blood test for LH, your LH level will be low. So what you're going to do is you're going to give a GnRH stimulation test. So you're going to exogenously, we have GnRH preparation like leuprolide, okay, goserelin. We have this exogenous gonadotropin releasing GnRH preparation. So exogenously, you're going to inject this patient with GnRH, and you're going to check the level of LH. If there's an LH rise, then it is a central precocious puberty. That means the negative feedback is acting. Okay. But if the LH, there is no rise, that means it is a case of peripheral precocious puberty. So GnRH, I basically got this MCQs to explain the GnRH stimulation test to differentiate central versus a peripheral precocious puberty. What about this? The answer to this? Okay. A girl has delayed puberty with low FSH and LH levels. What is the likely diagnosis? Can I have the answer to this? They're saying that it is hypogonadotropic hypogonadism. Yes, that's the correct answer. Why? Because see, one thing is delayed puberty. So now we need to differentiate if it's at the central level or the peripheral level. Okay. So if the FSH and the LH level are low, that means there is no stimulation from the higher up. GnRH will not secrete. Okay, because there is no GnRH, there is no FSH, LH. What will happen is the gonads will fail, and it will lead to low level of estrogen and estrogen. Okay, so this is a case of hypogonadotropic hypogonadism. So the central level itself is not stimulating for the gonads to secrete. That is hypogonadotropic hypogonadism. If it was hyper, okay, what about the next case? A girl with delayed puberty has high FSH and LH. What is the likely cause? Yes, this is a case of ovarian failure. Okay. If the ovaries are functioning, the high level of FSH and LH will stimulate the ovaries. Okay. And the ovaries will act. But what has happened is the FSH and LH will continue, secreting, thinking that they are not the ones working properly. But rather, what has happened is they are functioning properly. The end organ is not acting on that. So there is no end organ for it to send stimulus back. Okay, fine, that's enough. Stop. I'm acting. There's no, impulse being sent back. Okay, so that is when you see the ovarian failure. This is what we're talking about. This Turner syndrome. Okay, the ovaries itself are not functioning. Though there is stimulus from higher up, the ovaries are not functioning. That is ovarian failure. Okay. It is not hypothalamic dysfunction because FSH and LH wouldn't have, gone to higher level. If in this question, there's a question where somebody mentions that though initial cycles are can be anovulatory, you can attribute the delay in periods to anovulation. What about the ones in whom it persists? Now the persistence needs to be first evaluated if there's any other cause for this persistence on in cycles not being regular. Most common cause nowadays is PCOS. That has to be evaluated for. Okay, if not, it can be a constitutional way in which the body itself will, the cycles will be in that manner. It will continue to remain in that manner. Okay, but it's of utmost importance that you rule out other causes. Okay, fine. Let's go to the next question. The levels of FSH and LH, okay, the blood levels, it always depends on what day of cycle it is done. Okay, you have various ranges. Okay, that is the range always is when you have a lab report, they will tell you, okay, from this day of cycle in the follicular phase, what should be the level in the ovulatory phase, what should be the level. So that you cannot have a exact level of FSH and LH. Okay, it always varies with the cycle. But high level of FSH, we say if it is more than 40 nanogram per ml. Okay. Okay, what about this question? A 16-year-old girl presents with no breast development, primary amenorrhea, loss of smell, and then the lab finding says that there's low LH and FSH. What is the likely diagnosis? So this is a case where you need to understand that, your puberty, your nose has a role to play in puberty. Okay, this question I thought about to explain that. What happens is the nasal placode, okay, at the developmental and the embryonic life, and the nasal placode is where the GnRH, the neurons are present, and then they migrate to the hypothalamus. Okay, so this migration, if it has become defective, it leads to a syndrome called the Kalman syndrome. In Kalman syndrome, because of this defective non-migration of the GnRH receptors from the olfactory placode, if it has not migrated to the hypothalamus, they will end up with no secretion of GnRH. Because if there is no secretion of GnRH, there is low FSH, there is low LH. Because of low FSH, low LH, there is no stimulation of the ovaries. Because of that, there is no development of breast. There is no onset of menstruation, and because there is involvement of your nose, there is anosmia as well. Okay, so this is a typical case of Kalman syndrome, which is one of the cause for delayed puberty. Okay, now that we're done with the puberty, the next topic is pregnancy. So what happens to these hormones during pregnancy? In pregnancy word always you need to correlate it with progesterone. During pregnancy, the progesterone level will increase. So what happens is when the woman conceives initially, okay, the progesterone gets secreted by the corpus luteum. Okay, so once the trophoblasts take over, what happens is the trophoblast will secrete HCG, which will secrete the progesterone. Okay, after that, what happens is at 8 to 10 weeks, the placenta takes over. Once the placenta takes over, then the placenta will secrete. So it is something which an endocrine organ, okay, which is not there throughout your life, and suddenly there's a new endocrine organ being formed, which starts secreting hormones. So that is the beauty of placenta. Okay, it secretes progesterone mainly. It also secretes estrogen, and it secretes HCG and human placental lactogen. Okay, so these are all the placental hormones. So in pregnancy, you have a high level of estrogen and progesterone, which will give a negative feedback to the FSH and LH, telling, okay, don't send more signals from your end and don't cause further ovulation or further menstruation. Okay, and it's saying no to that. So that this is the changes in your hormones taking place during pregnancy. So pregnancy main hormone is progesterone. This progesterone initially gets secreted by your corpus luteum, then it gets taken over by the trophoblastic tissue. Okay, then finally at 8 to 10 weeks, the main the new organ, which the new thing which is formed is your placenta, which takes over all this function till delivery. MRKH syndrome is you have the gonadal failure. Yes, that is also taking place in MRKH syndrome. Okay, so what happens is, what about this question? A pregnant woman has suppressed FSH and LH levels. What do you think is the reason for this? Why is FSH and LH suppressed in pregnancy? Yes. So in pregnancy, as we discussed, the placenta will secrete estrogen and progesterone high level. Okay. Once it becomes in a very high level, it will send negative feedback to FSH and LH saying, no, please don't send more signals from your end. And that is why there is no menstruation or ovulation taking place in pregnancy. Okay, next we'll be talking about what happens during lactation. Okay, the hormones, the play of hormones in lactation. In lactation, again, lactation, the main hormone here is prolactin. Okay, prolactin, it is responsible for production of milk. Oxytocin is responsible for the release of milk. Okay, so now for this lactation to occur, you have two main pathways. One is the prolactin pathway, next is the oxytocin pathway. In prolactin pathway, what happens is the hypothalamus, it normally what it does is it secretes dopamine. Dopamine and prolactin are enemies. Okay, in the sense, dopamine, it keeps prolactin in an inhibited state. Now what happens during lactation? During lactation, as the baby suckles, it sends, the suckling will send impulses to the hypothalamus. And what it does is it will reduce the level of dopamine. Once dopamine level falls, the prolactin level from the antipituitary will get released, and that will lead to the production of prolactin. Now, what does prolactin does? It stimulates the alveolar cells in the breast tissue to synthesize milk. Okay, so that is how prolactin, which is suppressed throughout, will start acting. Why? Because the stimulus of suckling will reduce the level of dopamine. Once dopamine reduces, so it's always acting in that opposite direction, in the sense, inversely acting is dopamine and prolactin. So if prolactin level drops, dopamine level drops, prolactin level increases, prolactin will secreted from the pituitary will lead to the synthesis of milk from the alveolar cells of the breast. Now, once the milk is formed, the milk has to get ejected from the breast. So what is responsible for that? Now comes the role of oxytocin. Oxytocin, here what happens is once during suckling, the hypothalamus it will send signals to the posterior pituitary. Posterior pituitary will release oxytocin. Now this oxytocin will come and act over the breast tissue. That means the myoepithelial cells. Okay, you have the alveolar cells and the myoepithelial cells around it. So in the alveolus, you have the milk, the myoepithelial cells are around it. It will contract and it will lead to the ejection of the milk. So this is how lactation occurs, okay, under the influence of prolactin and oxytocin. Prolactin produces milk, oxytocin ejects that or releases that milk. Why there is no lactation occurring in pregnancy? This is because in pregnancy, there's a very high level of estrogen and progesterone, which will inhibit the secretion of prolactin. Also, dopamine will inhibit the secretion of prolactin. Okay. Why no ovulation taking place during breastfeeding? This is because prolactin will suppress GnRH. So that's why you have that lactation amenorrhea. No? Why? Because this prolactin will inhibit GnRH. And if GnRH is inhibited, it will not stimulate FSH and LH. If FSH and LH is not stimulated, there's no ovulation occurring. Can I get answers to these questions? First question is, suckling leads to increased prolactin secretion by, what is the mechanism? Yes, suckling will decrease dopamine. So answer is B, decreasing dopamine levels. Because dopamine decreases, prolactin increases, and that leads to milk formation. Okay. What about question number 2? Why does milk secretion not occur during pregnancy despite high prolactin levels? Yeah, it might seem like B, but more than dopamine. Dopamine is normally also present. Okay. But what is the difference in like non-pregnant state also? Why you're not having in non-pregnant state there is no prolactin secretion? Why? That is because of action of dopamine. But in pregnancy, you have this increased level of estrogen progesterone, which is inhibiting prolactin action. Okay. Please don't get confused between these two options, B and option C. The answer is C, because the question is pregnancy. Okay, pregnancy, you have high level of estrogen progesterone, which will inhibit the secretion of prolactin. So answer is C. What about question number 3? After delivery, initiation of lactation occurs due to what? Yeah, so again, it's quite simple, no? Because in after delivery, the progesterone estrogen level will fall because placenta is out. When the placenta goes out, estrogen progesterone will fall. Because of the fall in estrogen progesterone, your prolactin inhibition will go off and lactation will set in. Okay, good. Fine. Now, we are almost reaching the end of the class. Okay, before conclusion, I'll talk about menopause. Okay, the last phase that the woman goes through is that of menopause. Okay, so in menopause, what happens is, see, in a female, no, what you need to understand is there's just a set number of follicles. Okay, she's born with a set number of follicles, not like a male where sperm production goes on and on and on. It's not like that in female. They are born with a set number of follicles. Okay, so as we know, each cycle, so many follicles get recruited. Only one of them matures, the rest of them undergo atresia. Okay, so the cycle continues. Still, all the follicles undergo depletion. There is no more follicles present in her. Okay, so she cannot further conceive. Okay, because she's not able to so ovarian reserve is done. Okay, so once the ovarian reserve has completely gone to 0, okay, that means there's no more functioning of the ovaries, because of which, as your age advances, decreased number of follicles, that means there is no production of estrogen. Okay, so that's when she's hit menopause. Now, because of low level of there's a fall, because there's a fall in level of estrogen, there's a loss of the negative feedback. Okay. Now there's no more giving negative feedback. There's no more stimulating FSH and LH to stop because there's no estrogen. Now, because of no estrogen, the FSH and LH will try to stimulate the ovary. Okay, no, try and produce something. No, but eggs are not there. Okay, so there'll be no more estrogen. So there will be pituitary overactivity. So what signals are taking place now is estrogen is not there anymore. And estrogen, because it's not able to send negative feedback, but the pituitary will think, okay, fine, maybe I'm the one not functioning properly, so it's going to secrete more and more FSH and LH. Okay, so what you see in menopause is an increased level of FSH and LH. So to confirm that the patient has actually attained menopause or not, you're going to check the level of FSH. If it's more than 40 nanogram per ml, it is said that she has attained menopause. And this the increase in FSH is more than the increase in level of LH. This is because there's another hormone called inhibin. Now that its activity is also stopped. Inhibin will also try to regulate FSH. Now inhibin action is also stopped because there is no more follicles present. Okay, because of no more follicles being present, this FSH will become very high. Okay, so that is what is occurring in menopause. So what are the clinical features of menopause? You have vasomotor symptoms like hot flushes, night sweats. This is due to the hypothalamic instability. Okay, that she'll experience all these vasomotor symptoms. Then you have genital changes. Okay, so basically wherever you have had estrogen, okay, the breast tissues become atrophic, the vagina becomes atrophic, there'll be dryness of the vagina. Okay, the lubrication of vagina will be gone. So all this is because of deficiency of estrogen. Okay, then she will undergo osteoporosis. It's because of the loss of bone. What happens is estrogen normally it inhibits the bone resorption. So now that estrogen is no more available, the bones will undergo resorption. And then estrogen it had a protective effect over the heart. Okay, now that is also gone, she is more at the risk of cerebrovascular accidents. So these are the clinical features in menopause, which occurs because of a fall in level of estrogen. The last concept is that of contraception. Okay, now in contraception, again, the hormones we are going to exogenously give hormones like estrogen and progesterone. Okay, most important action is by giving OCPs, oral contraceptive pills, is when you're giving estrogen and progesterone, it will give a negative feedback. You're exogenously giving the patient estrogen and progesterone. So the level of estrogen and progesterone will increase. So it will give a negative feedback to the brain. Okay, no, don't send signals. So when it says don't send signals, the GnRH level will fall, FSH level will fall, LH level will fall. So because of a fall in all of this, there will be no ovulation taking place. So that is how the action of contraception occurs in combined estrogen and progesterone OCPs. Okay, what happens when you give only progesterone? Progesterone effect is it will thicken the cervical mucus. Once cervical mucus becomes thick, it will not let sperm ascend. Okay. And then what happens is endometrial changes. Again, because of this high level of estrogen and progesterone, the endometrium also becomes unfavorable for implantation. So the various types of contraception, you have combined estrogen progesterone. That means it has the combined OCPs. What it does is it will suppress ovulation. Okay, and it is also used in cycle regularization. This is the most common used OCP. Then you have progesterone only pill, where your estrogen also has its own set of side effects. Okay, so in order to avoid that, you are going to give progesterone only pill, because of which how does this act? It thickens the cervical mucus, it makes the endometrium hostile, and sometimes it can even prevent or suppress ovulation. It is mainly used in a breastfeeding mother where estrogen is contraindicated. Next, you have long-acting methods. Long-acting methods, you have long-acting injectable contraception, progesterone or implant. These are all progesterone-based. Long-actings are always progesterone-based. Okay. So this is how, exogenously, if you have given hormones, how does it act in the form of oral contraceptive pills? Okay, let's just revise what we have studied by going through this slide. In this, okay, so GnRH hormone sources hypothalamus, it stimulates FSH and LH secretion. Okay, continuous secretion will suppress the axis. Okay, that is why it's always in a pulsatile fashion that it is getting secreted. Next, FSH is secreted by the anterior pituitary, which its main action is follicular growth, granulosa cell stimulation, and estrogen production. It is the first hormone to rise in case of in puberty. Then you have LH hormone, which is secreted by the anterior pituitary. LH hormone is mainly responsible for ovulation to take place. LH surge will trigger ovulation. Estrogen, what happens is, estrogen is secreted by the Graafian follicle. It is also secreted by placenta. It is mainly responsible for endometrial proliferation, that is the proliferative phase of the endometrium, and for the development of the breast. High level of estrogen is required for a lead surge. Then progesterone, it is secreted by the corpus luteum and also the placenta in pregnancy. It maintains the endometrium, okay, and it inhibits the uterine contractions. And it is a hormone of it's also called as a pregnancy hormone. Next you have inhibin. You have inhibin A and inhibin D. Inhibin A is secreted by the granulosa cell. Okay, this inhibits the FSH secretion. So FSH secretion also gets inhibited by inhibin. Okay, and it regulates follicular recruitment. Then you have prolactin. Prolactin is secreted by the anterior pituitary. Okay, it's responsible for milk production. It suppresses GnRH and it causes amenorrhea. Okay, during the lactation phase. Oxytocin is secreted by the posterior pituitary. Okay, this is responsible for milk ejection or milk release, and it leads to the milk letdown reflex. HCG, that is human chorionic gonadotropin, it is secreted by the placenta. Okay, it maintains the corpus luteum initially till the placenta takes over, and this is the basis of the pregnancy test, UPT test, that is done by the level of assessment of HCG, beta HCG. Okay, then you have human placental lactogen, which is secreted by the placenta. Okay, it causes insulin resistance. Okay, and it supports, so the baby needs glucose, isn't it? So what HPL does is it causes insulin resistance so that more glucose goes to the baby. Okay, but if it goes haywire, then it causes gestational diabetes. Okay, then what about androgens? Okay, androgens, we know that it's the theca cells. Okay, which leads to conversion of cholesterol to androgen. Okay, now this theca cells will secrete androgen, and also the adrenal glands will secrete androgen in a female. Okay, and this is responsible for your adrenarche. That means the expression of this thing, your axillary and the pubic hair. Okay, and this level is increased in case of PCOS, because in PCOS what happens is granulosa cell, there is no ovulation taking place. There's just multiple follicles which don't mature. Okay, because of this, the theca cell will have increased stimulation by the LH, and it gets converted more of conversion of cholesterol to androgen. So there's more of androgen formation. Okay, because this androgen will not get converted to estrogen, she will have all the male features of hirsutism, acne, acanthus nigricans, and ovulatory cycles. Okay, that is in case of PCOS. You get to see a high level of androgen levels. The last hormone is that of thyroid hormone, secreted by thyroid gland. It regulates the menstrual cycle indirectly. Okay, hypothyroidism can cause menstrual irregularities. Both hypo and hyperthyroidism can cause menstrual irregularities. With this, I conclude my class. Let's be open for questions now.
Thank you, doctor. Thank you so much. I don't think there are any questions left to ask, but still let's open Q&A session. Doctors can drop your questions. Meanwhile, I'll also drop certificate link on the chat box so that you can fill the form to get your certificates. If there's any questions, please drop in the chat box to get your answers. And I think the session was so interactive that you doctor kept on answering all your questions in between.
Yeah. A woman can freeze her. There's a question on. 1 second. I'll just.
Oh, wonderful session, ma'am. Thank you very much. I don't know the name. V277 more classes from Dr. Arshia.
Oh yeah, thank you. There's a question here. Till what age a woman can freeze her eggs? Okay, till the eggs get exhausted. Okay, as I told you, till she attains menopause. So what you can do is you can assess the level of anti-Mullerian hormone (AMH) levels. Okay, or you can even do something called follicular study. Okay, where you can check the ovarian reserve. Okay, by doing an ultrasound to know, what is how good her ovaries are for her to preserve. Okay, so by doing any of these tests, she can know the status of her eggs, as to how well they are to um uh, to continue with their function. So she can assess her ovarian reserve by doing these tests, and if all that is normal, so till that age, till she attain menopause, her eggs are ready to be frozen. Now, what is a normal endometrial thickness? Yeah, that's a good question. Normally, what happens is in the first half of the cycle, the endometrium will be, we measure in terms of okay, millimeter. Okay, one thing is in first half of the cycle, it will be normally in the range of 6 to 8 Okay, once it can go maybe up to maximum 10. Okay, but in the second half of the cycle is because of the action of progesterone, it becomes much more thicker. It can go up to 14 to 16 to 18 it can go up to. Okay. If it goes much higher than that, it becomes abnormally thickened endometrium, which would need evaluation. Okay. So first half, the endometrium will be thinner, but it does have the normal range. Second half, it becomes more thicker. But again, there's a normal range to it. Much higher than that is a thickened endometrium, which needs evaluation. Thank you for all your valuable feedback. After this question here, after menopause, can she conceive? Okay, how can she conceive after menopause? Okay, after menopause, there are no more eggs, isn't it? So how is there a question on conception? Menopause itself says pause your conceiving. Okay, so there's no more conception after menopause. Somebody's attended the class in the middle of the session. I think they can get the
Yeah,
recording of
they
that.
can access the
Yeah.
video from live section in our YouTube channel.
There are some more questions. What is the role of blood thinner in menopausal women in case of palpitation? More of a medicine question. But I don't know what is the role of giving blood thinner in palpitation. There's no role of giving blood thinners in palpitation. But that's an entirely medicine question. Okay. I could talk about maybe HRT. That would have been a more relevant question for me. Okay. HRT is something which is hormone replacement therapy that you give after menopause. Okay. It is mainly, to overcome the symptoms of menopause like hot flushes, osteoporosis, okay, all the skin changes or the hair related changes. Okay, in order to overcome all of that, you have hormone replacement therapy, which I could explain to you about. Blood thinner and palpitation, more of a medicine related question. Okay, in case of a thin endometrium, yes, that's a very relevant question. How do you intervene in thin endometrium? Thin endometrium is something you will encounter while treatment of infertility. What happens is in infertility, if you encounter a thin endometrium, okay, you can prime that endometrium with estrogen first. Okay, once she's ovulated, you can exogenously give progesterone. So exogenously supplementing with estrogen first and then progesterone will help in building the triple line of endometrium that is needed for implantation. Okay, the question for egg freezing and menopause and pregnancy. Okay, what else happens in once, okay, even if you have attained menopause and you've frozen the eggs and now you want to use that eggs. Now what will happen is your uterus has shrunken. Okay, there's atrophic changes that has taken place in your uterus, atrophic changes that has taken place in your external genitalia. Okay, and the endometrium has become thin. So there is no more reproduction, even though you've frozen your eggs and you're trying to become pregnant after menopause. Okay. If the cycle is increased like 2 to 3 months, menstrual phase become increased, which is annoying to patient in a 15-year-old Does it need evaluation, or it will become normal as age proceeds, ma'am? Her menarche 12-year-old. Okay. This question. I didn't really understand this question. If cycle is increased like 2 to 3.
Dr. Asifa, next time, please be, I mean, to all the doctors, next time, please be very clear with your questions. That will help us to answer with more conviction. I am right, doctor. Am I right?
Yes, yes, that's what. If it's framed in a very
Yeah, please keep it straight. Please
cleanly.
Anyway, moving on. Doctor, we have one more question from Kiran says, how to intervene with high androgens?
High androgen levels, which you see in PCOS. Okay. So what happens is in PCOS, because a lot of follicles are getting immaturely formed. Okay. So what we do is we'll try to suppress this increased level of androgens. Okay. So as a result of high androgen, she will have hirsutism. So what we need to take care in PCOS is try to reduce that androgen levels, which can be done by diet and exercise. Okay, so main factor in PCOS is obesity or an unhealthy lifestyle. Okay, so once she tries to regulate that, the androgen levels will naturally fall. But the hirsutism which has already occurred, she'll need to either undergo some sort of laser or epilation of the hair. Okay, either one of those things can be done. But mainstay of treatment in PCOS is you try to suppress this excessive level of polycysts being formed, that is by the lifestyle change, because once you suppress this, you can lead to regularization of cycle, further reducing androgen. Another thing what we do is we will give OCPs. OCPs will also take care of the increased level of androgen.
Great. Thank you, doctor. Thank you so much for answering that question. Dr. Sohail is telling excellent session, ma'am. Putvika is saying excellent class. Dr. Atharva is saying thanks, ma'am. Dr. Geetika Gupta says thank you, ma'am, for an excellent session. Dr. Amrita Priyadashini says thank you so much, ma'am, for such nice class. I expect more class from ma'am. Dr. Ravli says I had a great time learning from you, ma'am. Thank you so much.
Thank you. Thank you so much.
Thank you, doctor. Thank you so much for joining this evening and enlightening us on this very particular topic. Uh, Thank you so much. And thanks to all doctors for attending the session. The month has ended and we have successfully conducted almost 8 to 10 webinars in the month of March. So April, we have a lot in store. We will be releasing our calendar for the month of April very soon. So please keep eye on social media channels. Keep eye on your social media channels. I'll just drop social media links on the chat box so that it will be easy for you guys to reach our social media. And please do follow us on social media so that you can keep update on all our updates. Thank you so much, doctor. Again, it gives me immense pleasure to extend our heart from regards for you to joining today. And like people say, is asking, we want more classes from you. We'll do that. And this is one thing I want to tell you that about Mediversal Academy. We always try to do what our students want, what our candidates want. We hear to you, we hear you, we listen, and we get into action. Thank you so much for all.
Thank you.
Happy learning all, and do visit our social media channel to stay updated on all our upcoming webinars. We have really good sessions in the month of April, and Dr. Arshia's also class will be there in the April. So looking for that, and thank you all. Good night.
Thank you, everybody. Thank you. Bye-bye.
Bye-bye, doctor. Good night.